Welcome back to Local Matters on KTLO. I'm Heather Loftus. Joining me now is Dr. Wynn Moore of the Baxter Regional Medical Center Bone and Joint Clinic. Dr. Moore, welcome to Local Matters.
Thank you. Glad to be here.
Tell us about your work here in Mountain Home. You moved here several years ago.
We've been here going on 9 years, 8.5 years, something like that. Yeah, we moved here from the Boot Hill of Missouri.
Really?
Yeah, we had been coming here for years. I actually started coming to Mountain Home in the 80s when I was in residency, fishing, and just finally circled back around and actually interviewed here 20-something years ago, but went out to Kansas, loved to hunt, so went out there. But I finally migrated back. We decided we really wanted to live here, so we packed up from Missouri and moved down.
Do you find any time to fish?
No, that's the problem. When I would come for a week, I'd fish all I wanted to.
Right, I've heard that. I've heard that from several people.
I can't do it. I go look at the river. Hey, it's pretty. Got to go back to work.
Well, I know your work at the Baxter Regional Bone and Joint Clinic keeps you busy. Tell us about the clinic.
Well, we're basically a general orthopedic clinic. We pretty much cover everything in orthopedics from trauma to joint replacement. We do see pediatrics. We don't necessarily do all of pediatrics. There are certain things in pediatric orthopedics that really need to go to a pediatric surgeon, particularly spines and hip dysplasia. But most fractures and injuries in the pediatric population we take care of, so that makes us a fairly balanced clinic. We focus a lot on joint replacement. That's probably half of our business. Then the rest of it is a mixture of sports medicine and trauma. Obviously, that's a big, and it fluctuates year to year, as you can imagine. When you have a lot of trauma one year, your business is skewed that way. But we're a fairly balanced clinic.
Joint replacement. Are we talking hips?
We do all joints. I don't do ankles anymore. That's something that is so rare. But hips, knees, and shoulders. That's the big three. Rarely do I see an elbow that would benefit from replacement, so I generally send those to someone that does them every day, although they're probably one of the least complex to do, but mostly hip, knees, and shoulders.
Let's talk about hips for a second. Obviously we live in a retirement community. You probably see more hips than you would in another market. How has hip surgery changed over the years?
Well, the concepts of hip replacement, as you know, have been coming for many years. First of all, we went through some implant changes. The original implants were, if you look back at some of those, you think, wow, I can't believe they put that in the hip. So implant design changed, and that continues to change. One of the things that's probably happened in the last 5 or so years, really about 10 if you count a little bit of Dr. Mata's original work with the anterior hip approach. In the last 5 or 6 years, it has really become widespread to go through the direct anterior approach, which is a change, not really in the implants per se, but in the way we put it in. That's made a big difference for patients. Certainly recovery time is better. Then we also have moved in other areas of total joints, we've moved to oxinium-coated implants, which is a big plus when you talk about metal allergy. That's a big issue. It's a big issue now in the literature. It's really a small population that develop it, but if you do, it's a problem. So with the new oxinium-coated, which Baxter Regional is probably one of the only, I would say the only hospital in the state of Arkansas that solely puts in oxinium-coated total knees.
Really?
All of our total knees are oxinium-coated or titanium base plate. So basically, you're hypoallergenic. The one thing we haven't gotten, our technology hasn't changed, is the cement. And you can still be allergic to cement. Rare, very rare. But from the metal standpoint, we're getting that covered.
From a rehab standpoint, it seems like, no offense, but you guys want us, whatever surgery we have, up and walking as quickly as possible. Is that true?
Absolutely.
Why?
Well, there's a couple reasons. Well, first of all, let's say that not everybody we want to walk. If we have an implant that maybe has the bone stock is not good, or we're worried about it needs to heal in some, we won't push them to put weight on it, but we want them moving. The bottom line is, if you're in bed, you're going to get pneumonia. You've got to get up. The patients that are particularly patients over 65. You end up with pneumonia very quickly. You don't want them in bed. You want them up. Dependent lung expansion, walking.
So it's about the lungs and not the injury.
It's all about the injury, too, in a sense that, think about it, if you have even a bruise, you sit around and baby it, it hurts forever.
Right.
You can work through it. It's all about getting the patient back to their normal activity, what they need to be doing. So, yeah, we put a hip or knee in you. We want you to move, get up and go. And there are some situations where we don't necessarily do that. I'll tell you a funny story. My father, general surgery is the same way. I mean, when they do abdominal surgery, they want you up. You don't want to get an ileus. You don't want to get pneumonia, so that you're up. And my father, I can remember him coming home one day, and he was father's general surgeon, and he was laughing to himself. And I thought, "What, Dad? What are you talking? What's going on here?" He goes, "Well, I had this patient that had a gallbladder on this morning, and the family. I saw him post-op, and the family asked me how she was doing and everything, and I told them that she was up and walking. And she goes, the family goes, Dr. Moore, Mother hasn't walked in like 2 years." It's like, well, she's walking now. I mean, the point was he was getting her up no matter what. And so it's important to us to get back to walking, deep breathing, all the things that keep us healthy. So, yeah, we do push our patients.
Obviously, when it comes to some of our seniors who have to go in for those hip and knee replacement surgeries, they have weakened a little bit, maybe due to the injury of the hip or the knee, and they're not as active as they once was. Their upper body is not as strong as it once was. Do you want to see your patients get to a certain level before you'll go ahead with surgery? Is there a mark that you want to see there, or it's
something? Are you talking about in fracture or in replacement?
In replacement.
Absolutely. I mean, we would love to see them do exercises, upper body strengthening, anything that improves their overall condition. Now, the challenge is, as far as walking, some patients just can't walk that well. They hurt so bad, you can't, I love that where somebody says, well, I was told I had to lose 100 pounds, but I can't walk. And that's true. Some patients just can't walk enough to lose weight. So that's a limitation we have to deal with. But upper body strength, anything we can do to make them healthier before they have surgery speeds up their recovery. No doubt about it.
All right. Let's take a break. You're listening to Local Matters on KTLO.